Hello, everybody, and welcome to the NCHCMC HIV in Brief webinar series. Today's topic is antiretroviral adherence. My name is Stefan Perez, and I'm one of the HIV clinical specialists with the NCHCMC and Health HIV. Today we're going to be discussing these learning objectives. We'll define adherence as it relates to antiretroviral therapy. We'll discuss current positive and negative predictors of adherence. We'll describe methods for improving adherence, and we'll identify some effective strategies for increasing patient adherence in the clinical setting. In order to define adherence, we first should look at adherence through two different lenses. Adherence in the traditional sense is taking medications or treatments as prescribed or advised by the healthcare provider. When we talk about antiretroviral adherence, we look at it in the scope of what percentage of antiretrovirals need to be taken in order to minimize the risk of resistance. ARV adherence is defined as taking greater than 95% of your prescribed regimen. For antiretroviral regimens, this is tantamount to missing 2 to 3 doses a month for regimens that are twice a day. It's important to recall that these studies were done with earlier protease inhibitors and antiretroviral medications. Newer studies suggest that the potency of boosted protease inhibitors and NNRTIs may make for more forgiving regimens that could stand adherence at approximately 80 to 70% that prevent against adherence. When discussing adherence, we also know that providers typically are often inaccurate in terms of their assessments of patient adherence, and that patients' self-report of adherence predictably overestimates adherence by as much as 20%. It's also important to recognize that there is no gold standard for assessment. So why does adherence matter? Well, it reduces the rates of resistance, it improves quality of life for patients living with HIV, and it improves virologic suppression. And viral suppression is key as the community viral load begins to decrease with adherence, or as the individual viral load begins to decrease with adherence, the positive effects are manyfold. In terms of predicting adherence, much of the focus has been on predicting non-adherence, so we don't have as much data about what contributes to good adherence, but we assume they would be the converse of those that negatively predict adherence. So some positive predictors can be the ability to identify medications, the ability to describe the proper dosing, and of course lower pill burden. And some research suggests that the difference between twice-a-day dosing and once-a-day dosing strongly correlates to adherence, with once-a-day dosing much more effective in promoting good adherence. Interestingly enough, some studies also show that there is no difference between better adherence in patients who take 1 pill a day versus 3 pills once a day. So it seems to be that how many times a day a patient needs to take a medication is more strongly correlated with adherence than how many pills they need to take during the day. Predicting adherence, again, can be a difficult task for the provider. Factors associated with non-adherence include younger age, age-related changes, mental health and social issues including depression or active substance use, non-disclosure of HIV status, side effects, and again, complexity of regimens. Another predictor of non-adherence is a patient's adherence to care. For instance, if a patient typically has difficulty adhering to their clinic appointments, they also may have difficulty adhering to their medication regimen. It's very important to remember that many patients face many of these predictors of non-adherence throughout the course of their lives and throughout the course of their treatment. So it's important that the provider and the treatment advocate remind themselves that these can change, the patient situation can change very rapidly. And it's also important to remember that race, age, sex and a past history of substance abuse are not associated with poor adherence. Now, there is no gold standard for assessing adherence, but it's really important to remember to keep it simple and non-judgmental. Normalize less than perfect adherence and try to minimize socially desirable responses. Always try to ask about a finite amount of time when asking your patients or your clients about their adherence. So ask about the last 3 days. How many medications did they miss in the last 3 days, or how many medications in the last week? It's also important to ask whether or not they're missing other medications or other treatments. This may be an indicator that they may also be missing important medication doses. Pill boxes, bottle cap counters, dispensing systems, and sometimes biological markers are all other measures of adherence. These measures often are more labor intensive and need many more people to assess than a simple assessment done by the provider. However, they can be very useful in assessing adherence and non-adherence. When questioning a patient or a client about non-adherence or adherence, again, make it relatable and make it generalizable. We expect that patients will miss medication doses. It's nearly impossible to take 2-3 pills every single day and without missing any medications for the rest of their life. So, when talking about adherence, it's really important that we make this adherence generalizable and these questionnaires generalizable. So for instance, instead of asking a patient, how many medications have you missed in the instead of asking a patient, have you missed any medications, yes or no, again, share with them that missing medications is a normal part of treatment plan. And many people have missed medications, especially when they're initiating antiretroviral therapy for the first time. So how many have you missed? Have you missed any medications in the past week? Or have you missed any medications in the past 2 weeks since you initiated your antiretroviral therapy? These types of questions make the patient more comfortable in the care environment and sharing their adherence strategies. This is an example of some questions that you might be able to ask your client or your patient in order to assess their adherence. Some of the questions could be, do you manage your own medications? If not, who manages them for you? What medications do you take and what is their dosage? When do you take these medications? Do you take them with food or on an empty stomach? Do you take them in the morning or at night? Do you take them consistently at the same time of day? How do you remember to take your medications? Many patients use alarm clocks, text messaging systems, or other types of reminder systems that cue them in that their medication is due on a particular schedule. And then again, we come to some finite questions about medications. How many meds have you missed in the past 72 hours? Prospective questions are also really important when assessing adherence or when assessing the potential for a patient to be adherent to a regimen. So asking questions like, when are you most likely to miss doses? Or what are some barriers to adherence that you might have in your life right now? What is your work schedule like? What is your home life like? What are trying to anticipate some of those barriers so that you can bypass them in initiating your therapy? Then, of course, it's always very important to assess your patient about any adverse effects of medications. Experiencing adverse effects of medications is quite often a cause of non-adherence. So anticipating those adverse effects is very important, and also making sure that your client feels comfortable in discussing those adverse effects so that you can accurately assess their adherence and whether or not they're skipping doses to minimize side effects. A couple of other really important questions are questions about their comfort level in terms of taking medications in front of others, because there may be situations where they may have to take medications in front of others. If they're visiting families, if they're visiting family members, if they're out on a date, if they're in an intimate relationship with another person, they may be confronted with this obstacle, and it's very important to ask them if this may be a barrier to their required doses. In terms of some interventions for improving adherence, It's important to remember that no patient is the same, especially when talking about adherence, but assessment of the patient's readiness for antiretroviral therapy is key. And again, building in some of those questions about what might they foresee as barriers to taking their medications every day and adhering to their regimen. It's really important to use critical thinking when prescribing antiretroviral therapy, and this is because we have to anticipate what those barriers might be, even if the patient themselves may not be able to anticipate barriers. So if we know that a patient is working odd hours or working many hours, it may behoove us to think about the types of medications that we are going to prescribe and some of the side effects that the patient might be experiencing, so that we can adequately educate the patient on those side effects, when they're most likely to occur, and what to do to help treat them. Always very important to simplify a patient's regimen when possible. If a patient is eligible to take a lower dosing type of regimen, then it behooves us to offer that regimen to that patient, and it will make for a much more improved adherence, regimen with much improved adherence. It's also, again, very important to educate about side effects and adverse drug reaction. It's key to let the patient know that they're supported, that they can call the office, they can call the nurse, they can call their counselor, and let them know that they're experiencing side effects of medications. Sometimes we have to change the medicine from side effects, and sometimes we can support the patient medically through it. Very important to talk about the risks and benefits of therapy. It's also very important to, again, identify those barriers that patient may not have considered. Always try to use creative strategies. There's many different types of adherence modalities that are available: pill boxes, medisets, pre-filled medication packages from the pharmacy, home medication delivery, keychain pill boxes. There are several online websites that a patient can put their medications into a secure password-protected web page, and that web page will send them text message reminders on a daily basis to make sure that they've taken their medications. A few more strategies for improving adherence are assess for the readiness for use of some of these modalities. Some patients do not want to use medisets or pill boxes because they have not told anybody about their HIV status, and so bringing home a mediset or a pill box might prompt questions from those at home. It's also very important to use a multidisciplinary team when appropriate, and if you have access to it. It's key to improving adherence. If you can bring in a social worker, if you can bring in a nurse or another provider, if you can bring in a health coach or a medication counselor or a pharmacist, everybody plays a very important role in terms of improving the patient's adherence and counseling them around adherence and helping that patient to succeed. Always expect the unexpected. Patients can lose their medications. They can leave their medications on the plane. They can have it delivered to the wrong address. They can get violently ill one day from the medications and never want to take them again. So I always talk to my patients and my clients about expecting the unexpected. And even if something goes wrong, if something happens, let us know. I don't want you to come into clinic 2 weeks after you lost your medications and have you say, well, I just stopped taking them because I left them on the bus and I didn't want to bother anybody. So always teach your patients to expect the unexpected and give them a resource that they can follow if something like that happens. It's always important as well to remember to tell the patient that they should always try to have at least 1 or 2 days supply of pills on them, either in a backpack or in a lunch bag or in a purse, just in case something happens where they may be away from their meds unexpectedly for a day or two. And of course, it's important for all of us to hang in there. Adherence is inherently imperfect, and we can all achieve it together if we just hang in there. We know that our patients are going to miss medications. We know that we can't always give them all of the information that they need in one visit. So just hang in there and work together to achieve the optimal adherence for your patient. With that, I'm going to move into a case study. During this case study, you will have opportunity to sit and discuss with your care team members if you're watching this as a group, or you'll have opportunity to think about some of the responses to the questions that we pose. So all that we ask is that during that time you pause the webinar and restart the webinar once you're ready to move forward. So this is a case study in adherence. And you all now are adherence experts, and we all have our favorite techniques to use, but we're just going to try to use some of these techniques in a practical way and have a little bit of a discussion around how to practically help a patient with their adherence. So this is a case of Miss D. She's a 44-year-old HIV-positive African-American female, and she's been HIV positive for 9 years as far as she knows. She's presenting for her first HIV care visit in 3 years. She's not on any medications and she can't remember her last ARV regimen. She feels sick and she came in today to the clinic because she has a sore on her stomach. Her blood pressure is 86/54 and pulse is 130. Her temp is 101.4. Her intake labs were her CD4 count was 32 and her viral load was 132,000. And while these labs weren't recent because she had had difficulty coming into care, they were about 6 to 9 months old. She was actively drinking 6 to 10 beers a day and using crack cocaine off and on weekly. In addition to her initial presentation, her physical exam did yield some findings. In addition to the vitals, she did have a large open abscess and cellulitis on her abdomen, abscess on her right upper thigh, and palpable femoral nodes, and her weight was 86 pounds. We did do an ED referral for her immediately, and she ended up being admitted for 4 days and discharged on Bactrim and azithromycin. She did return. She did not come back for her initial follow-up after her hospitalization, but she did return 4 months later. She has remained. Her weight has remained the same, and she's not on any antiretroviral therapy at this time, and she has not been taking her trimethoprim sulfa or her azithromycin. Her blood pressure is 98/60 and her pulse is 110 and she's afebrile. Her substance use pattern is the same and she's relatively indifferent about meds and indifferent about her care in general at today's visit. She has been on meds before, and in engaging her with a printed a photograph of all of the medications that are available, she was able to elicit that she had been on lopinavir, ritonavir, and imtricitabine tenofovir combination. But she says that she stopped them because they, quote, tore up her stomach. Her previous records say that she does have an M184V mutation, which does yield some resistance to, particularly to the emtricitabine in her previous combination, but was undetectable previously. And she is currently sexually active with some inconsistent condom use, and she is uninsured at this time. So at this time I ask you to pause and discuss amongst yourselves or think about what might some of the barriers to adherence might Miss D be facing. Also, does she have anything going for her or any positive signs that she might be adherent to her upcoming treatment plan? Great. So in response to the previous questions, she does have some significant barriers to her adherence. She does have some active substance use. She is pretty ill. She's had previously while she's had a good virologic response to antiretroviral therapy, she did have some some very significant side effects which actually caused her to stop taking her antiretroviral therapy. And she has some inconsistency with her care. However, she does have some things that help us think that she may be adherence. First of all, she's in the clinic. She must be coming in for some reason, whether it be that she just feels sick or that she's ready to make a change. Sometimes our patients just come in because they don't feel good, but that's a way to sort of capture them, and if we can tell them that they'll feel well soon, that helps us to gain some trust with them. Another thing that she has going for her is that she's been undetectable in the past. So that tells us that even though she wasn't feeling good on her medication and she had some significant side effects, she still was able to adhere, relatively speaking, enough to get undetectable with her viral load. However, she does have some resistance in play with her M184V mutation, which suggests that she may have had some adherence issues in the past, even before her more previous regimen. So, we decide to, during this visit, try to investigate a little bit more about what might be going on with this patient. And so we actually called in our social worker, and our social worker met with her. Ms. D agreed to meet with her, and found out that her daughter and her have sort of a very disconnected, estranged relationship, mainly because of Ms. D's substance use. And Ms. D was also recently arrested for something, although she won't really share with us what that is. However, she does have a court case pending. And she has been told that if she can help to try to get, if she can become sober and if she can get her medical care on track, that may be beneficial to her in her upcoming court case. And she's actually verbalized with the social worker that she wants to get sober before her hearing. So these are some very, very, very positive things that are in positive indicators for Ms. D's future adherence. So again, I'd like you to pause the webinar at this time and address some of these questions that are on this slide. What are some of the barriers to adherence Ms. D might be facing, and what are some things that might facilitate her adherence or serve as goals to stay adherent? Great. So now we've discussed some of the barriers that she might be facing to adherence, and we've discussed some of the things that might facilitate her adherence over the next few months, both to care and treatment. So with our entire care team, we came together and decided that we would go ahead and begin her on treatment. We did recheck her labs because they were quite low at her most previous visit. Her CD4 count was 75, and her latest viral load is 89,000. We did go ahead and begin her on a once-daily emtricitabine and tenofovir fixed-dose combination, as well as darunavir and ritonavir. We enrolled her for one visit with the substance abuse counselor and the registered nurse case manager and the social worker. So we told her that if she could make that one visit, that we would squeeze everybody into that one visit. We also began her on Bactrim daily, and we preemptively counseled her and gave her over-the-counter medications for diarrhea and a prescription for some nausea medication as well. We worked out a visit schedule to assist her and assisted her with some transportation arrangements, and I agreed to write a letter of support for her court case. And then I made her a deal. And what I said was that if you could give us a year, if you could really give us 6 months to a year, I could guarantee her that she would be feeling better physically and probably feeling better emotionally, given that because she would be able to, because of a likely positive court case outcome, and also because she was working towards getting sober, that she would, by year's time, be able to feel more stronger and healthier, both physically and mentally. And I was pretty sure about the physically, but less sure about the mentally. But I thought that making her a deal was the way to move forward in this situation. And I think that sometimes when we are taking care of our patients, we're a little bit afraid to prognosticate a bit about their outcomes. But in this case, we have very good medications. We knew that if we could just get her on a very good regimen, a strong regimen, we would be able to likely get her undetectable and get her physically feeling better, which I thought would help her emotionally. And she agreed. So We did set her up with a registered nurse case manager who ended up providing her some further adherence counseling. And she ended up developing a really great relationship with this nurse case manager and agreed to see this nurse monthly. She did receive some counseling about diet. She only sees the provider now every 3 months, and she has been seeing the substance abuse counselor and social worker every 2 weeks as well. She likes that interaction. It did take a year for her to become undetectable, and she did have some significant periods where she missed doses and where she missed appointments. And still, she tends to miss about 1 or 2 doses a month. However, she was able to become undetectable in that year's time, and her weight came back very significantly. She's still struggling with some alcohol sobriety, but she has stopped crack cocaine use altogether. She did end up avoiding jail time, and she was maid of honor at her daughter's wedding the following year. And then this past Christmas, she ended up bringing pictures of her 4th grandchild to our clinic so that she could see, or so that we could see rather. So the take home from this case, and not every case is like this, and I do understand that, but the take home from this case and the take home from this webinar is that virologic suppression does begin with adherence, and ultimately it is up to the patient, but providers, nurses, case managers, health educators, everybody in the clinic environment plays a crucial role in helping the patient to maintain adherence. It's very important to always be creative and always be determined, and of course bring realistic expectations to your healthcare team and your patient around adherence. And as of one last note, I am sometimes confronted when I do this case study with providers by a very valid concern, and that concern is about time. And where can we find the time to do this for this patient? And obviously this does take time and intensity, but I was very far from alone in this particular case. I engaged our nurses, our social workers, our substance abuse counselors, our support groups, all of whom took responsibility for this patient's success. So I'd like to thank you again for your attention today, and please, if you have any questions regarding this or any of our other webinars, please feel free to email me at stefan@healthhiv.org. Thank you very much.